It's a little bit after the start time, which is not unusual. We have several people logged in now. So I'd like to welcome you to another in a continuing series of webinars from the Northwest Regional Telehealth Resource Center. And this is our first Adobe Connect webinar, so we're kind of excited about the new technology. I'm Bob Wolverton, the NRC TRC Program Director, and I'm doing the introduction today, and I'll kind of be monitoring the Q&A section. If there are any questions that I think need to be answered right away, I might interrupt Dr. Kamali to bring them to his attention. And also, I'd like to point out to you the survey link in the pod in the lower left corner of your screen. We'd like to have you complete an evaluation of today's webinar. And also, if you haven't already, subscribe to our newsletter. That comes out about every other month, and we have a lot of good information about what's going on in the region with telehealth. Everyone will be muted, so your questions will need to be typed into the Q&A pod at the bottom of the screen. And if I lose my voice in the middle of this introduction, I apologize, but there's something going on with my throat. Maybe I should have an ICU doc look at me. Our presenter today is Dr. Javid Kamali, who's the director of the Tele-ICU project at Providence, Alaska Medical Center in Anchorage. Dr. Kamali was born and raised in a small town south of Tehran, Iran, and then moved to Europe after high school. He attended medical school at the University of Vienna in Austria, and upon graduation moved to the US in 1999, where he did a residency in internal medicine at UPMC Pittsburgh, Pennsylvania, and followed that with a fellowship in pulmonary and critical care medicine at Albuquerque. After his training, Dr. Kamali moved to Alaska in 2007, and he was named director of the TeleICU project in April of 2009. Dr. Kamali's emphasis is on care delivery and standardization, regardless of geography, and helping distribute resources in a more efficient and effective way. It's my pleasure to introduce Dr. Javid Kamali. Dr. Kamali, go ahead.
Okay, I'm on now. Thank you, Bob, for the wonderful introduction. Thank you, Martha and Bob, for setting up this exciting project and the first tele presentation, and for the opportunity, everyone, for coming to this meeting and letting me talk about the TeleICU in general. It wasn't me. So I'm going to talk about the TeleICU in general for non-intensivists, and it's a very broad topic, and it's hard to really hit every single aspect of TeleICU in a 45-minute presentation, but I'm hoping that I can highlight the key components of that. But before I get into TeleICU, I think it's important that we talk about the big picture, where we are in terms of a system. You are all part of the board, and you are the leaders in application of telemedicine in general and telehealth in your communities. So a lot of that applies to general non-ICU population as well. And I'm going to talk about that and try to get as much information in a short period of time as I can. First of all, I have no conflict of interest. And the objectives of this 45-minute talk, again, the two first objectives are not necessarily directly related to TeleICU, but are very, very important that we set this stage before we talk about the status of TeleICU in the US and Alaska. First thing, I would like to talk about the challenges in critical care, a lot of which, of course, applies to non-critical care healthcare delivery. And the second part, very briefly, I want to touch on models to improve delivery of critical care that has been offered through some national experts. And then, of course, I get back to the TeleICU. The real objective, and you will hear it a lot from me in the next 45 minutes, with the keyword of delivery, and that's something we've been missing. And believe it or not, I went to medical school in Austria, as Bob said. I did my residency, I did my fellowship, but I did not have a single hour about how to deliver what I've acknowledged during my medical school in terms of knowing the diseases and how to treat them. Not a single hour was dedicated to that, which I think is very important. So what I'm focusing is about how to deliver 21st century critical care to every patient every day, predictably and reliably. So what should we care? The ICUs, of course, is a small, from the number, is a small proportion of the patients. It's a big pie of medicine, and a small slice of that is critical care. But so why should we care about that? And I'm not saying that we should neglect the big picture of medicine and preventive medicine, but I'm trying to make my case that this is an important part of our healthcare system. In other words, if you ask me, between preventing a hemorrhagic stroke from elevated blood pressure, uncontrolled blood pressure, and treating the consequences of bleeding into the brain, which one would you choose? I would say, of course, prevention, because it's easier. A lot of time we miss the boat. Patients are running around with high blood pressure, and of course, at some point, many of them, we know it's a major risk factor for getting what we call intracranial hemorrhage in the brain. But when it happens, they present a significant challenge to our healthcare society. But again, I'm not trying to focus on the big picture, just a small slice of the healthcare in terms of critical care. Number one, they're the most vulnerable patients. They have very little reserve for the organ failure that brought them to the ICU to begin with. And ICU is a very complex environment in terms of the severity of the disease of the patient, in terms of the staffing, of the equipment, of the care that we deliver. It's one of the most complicated environments I've ever worked with, and I've been in different businesses before that. For ICU patients, a small and timely intervention can be life-saving. Their condition changes continuously, as opposed to other patient population like outpatients or inpatients. And an example would be, dropping blood pressure. If we miss the boat, if we do not intervene in a timely manner, other organs fail as well. And it's also important to know that about a third of all deaths occur in the ICUs. We've got a lot better with discussion as an outpatient about end-of-life issues, but still about a third of us die in the ICUs. It hopefully will change, and a lot of us will have better advanced directives about that. And this one is a different statistics, but of all the all-comers to the ICU, about 10% die regardless of what we do. So it is significant. What is quite challenging is there is a significant variability in care delivery. The patient A with the same disease, same age, same acuity presents to hospital B gets a different care compared to presenting at the same time of the day, same weekday to the hospital C, and that's something has been quite challenging. And we know that if I end up with a stroke in a tiny little community in Alaska while I'm taking vacation, as opposed to being like across the street from a tertiary hospital, I get a different care for sure. Cost is a major issue, and we know that it's not only the expensive treatment that we offer to the patients, it's the staffing, it's the training, it's the medications that we use, and of course the duration and severity of the disease. So it is important for the healthcare in general. And in states, particularly in Alaska and a lot of northwest areas, we have significant logistical and geographical challenges in terms of resources. And of course, transfers are expensive. I talked about that with Cecily the other day, that going from one hospital across the street to another that has, let's say, dialysis options may cost up to $300. For us, it's thousands and thousands of dollars, $20,000 for a helicopter transfer or a fixed-wing plane transfer. So these are important issues that we should care about, critical care in general. Going to the next slide. I'm not going to go into the details of this case, but this is one of the cases that within the first week of me presenting to Alaska, working as an intensivist, I confronted this patient, and I just make the story short that he was a 41-year-old with severe septic shock from pneumonia who was under-resuscitated, and by the time the patient got to me, the game was over, and the patient had multiple organ failures, and we had missed the boat completely, and there was no way for me to reverse the course of the disease, and of course the patient expired. Again, I'm not going to go into details, but this patient possibly shouldn't have died if we had intervened a few days when the disease started. A couple of brief overview of some of the research studies about the impact of intensivists on patients' outcome. This is a study that was published in JAMA in 2002, and it showed the patient have lower hospital mortality with an odds ratio of 0.71 and lower ICU mortality of 0.61 in the staffing pattern of critical care patients when the intensivists are involved. This is another study by several national leaders in critical care. The effect of multidisciplinary care teams on intensive care unit mortality, just doing a round to make sure important issues have been addressed on a daily basis, has an impact on mortality. It's as simple as that. And they realized that the odds ratio for mortality was 0.78, much lower than 0.88 compared to a low intensity intensivist staffing. Quite interesting study. And again, why should we care? Why should we be concerned about the unsustainable trends in critical care staffing if we know that they make an impact? Just looking at the estimates of nursing demand compared to the supply, it is quite concerning that in 2020 the discrepancy between the number of nurses that graduate or are present compared to the need is huge, and it's getting worse every year. The same applies to the intensivists as well on the right side. I'm not going to go to the right side, which is pulmonologists, which is a little bit better, but just the trend of demand, which is blue, compared to the supply, which is fairly consistent over the next couple of years. It's quite concerning that the discrepancy between supply and demand of the intensivists, which we showed would make an impact in patients' outcome and care delivery, is getting worse year by year. Same applies to the nursing. In fact, it may be even worse. If we look, I'm sorry about the small size of the slides, but if we look at the trends, the demand is going proportionately is increasing as opposed to the demand, so as opposed to the supply, which is plateauing or even decreasing. And if you look below, you can see that almost a fourth of the nurses are less than 39 years old, meaning that in the next 10-20 years, the vast majority of our nurses will retire, and that is also quite concerning. Dr. Pronovost is my new hero, and the reason I am quite interested in following his way of practicing medicine is that he focuses on the delivery of care, and he says the task of medical science fall into three buckets: understanding disease biology and effective therapies. This is the vast majority, I mean almost exclusively what I spend in medical school, residency and fellowship. But the part that is delivery has not been taught and utilized effectively. That is something that he considers, he reports that we consider it as art of medicine, which is outrageous. It should be part of our job, part of our daily routine. Science, he says, science has been finding new genes, science has been finding new drugs, science has not been delivering care very wisely. And that, again, I'm trying to go back again and again why we are missing the boat in that regard. This is a really interesting book if you haven't read that. It's a book by a surgeon who actually doesn't write about critical care, but about the big picture of how we can impact our care with the same knowledge about the biology of the diseases and therapies, how we can impact outcome just by making sure that they're delivered appropriately. I'm going to skip the next couple of slides, but just briefly tell you that catheter-related bloodstream infections are quite a challenge in every ICU, in every hospital. They are very common, they're very deadly, 28,000 per year. They cost a lot, up to $23 billion per year, and they're preventable. So what Dr. Pronovas did, he applied a 5-item checklist that every non-medical patient looks at it and says, so you don't wash your hands, you don't clean the patient's skin, you don't drape the patient appropriately, you don't put a mask on or hat or gown or glove. What are you thinking? But believe it or not, he checked that these items are not consistently applied to the patient, and when he ensured that these 5 items are applied, the risk of catheter-related bloodstream infections dropped to 0 and persisted for years, which was extremely high in several of the Detroit hospitals. It's as simple as that. So we need to redesign the system. I'm not going to go into details on this slide. Very briefly, shifting the gear before we get to Tele-ICU, I'm sure several of you know Dr. Khan and Dr. Angus. They are very involved national leaders in terms of critical care and particularly sepsis. And then they realized that we are not delivering care in different systems in rural areas compared to larger tertiary hospitals, academic centers. And they offered 3 different options that could potentially help. One of them is tiered regionalization, one of them is ICU telemedicine, and the other one is regional outreach. And I'm not going to go into details with the other 2, but ICU telemedicine has been offered as a possible solution to make sure that we leverage our resources to deliver better critical care to our patients. Now, shifting gear to Tele-ICU, before we start, I just want to make sure that we are on the same page regarding some of the nomenclature that I'm using. VisiQ has been used interchangeably with Philips. It's a software company that developed the product EICU, and that was this company was bought by Philips in 2008. So you will hear VisiQ, you will hear Philips, you will hear Philips VisiQ. They're all pretty much mean the same thing. eCare Manager is the software that this company is using for electronic medical record. It has been developed by intensivists, so it's very user-friendly and fairly straightforward system to use. And this system has been used by the vast majority of the EICUs. So that you know, I'm not going to fast forward, but there are some other companies that have developed Tele-ICU products like Cerner. They are being used by some of the centers, but the vast majority uses the Philips product, eCare Manager. EICU is a trademarked name by VisiQ/Philips for Tele-ICU. So we use Tele-ICU and EICU pretty frequently interchangeably, but so that we know EICU is a trademarked name, it's like the as opposed to generic, which is Tele-ICU, is the brand name of Tele-ICU specifically for this company. And Tele-ICU again is the broad generic name for it that I'm going to use because again, many ICUs are not Tele-ICU, and we want to be objective and free of commercial bias. But again, because this company is so advanced, and even our own name is EICU, we use their name without any legal problems with Philips. So what is EICU? There's so many different versions and definitions of the EICU, but I think what I came up with best is a 2-liner of an off-site intensivist and critical care nurses driven support system using sophisticated monitoring and communication tools. So there's a lot more to that, and I'm going to expand on that in the next couple of slides. It was introduced as a possible option for improving care of the critically ill and injured. The story is how it started. It's quite interesting. EICU started in Baltimore, and the intensivists were quite often stuck in a traffic jam, and they said, why don't we come up with a site where we can monitor our patients, so when our intensivists are stuck in the traffic jam, somebody will look at our patients. And they did that, and after some time they said, oh, let's look at some of the data, and they realized that they are having a huge impact on care delivery of the ICU patients. And then I believe 2 or 3 of them decided to start up a company called VisiQ, and that was in 2000. And since then, the company has taken off and has done a lot of research and has expanded to a big part of the US. And again, this is a pure US company. There are some other tele-ICU projects, and I'm not very familiar with those internationally, but none of them are even close to the way we are practicing here in the US. What one common misunderstanding and misperception is that the EICU is frequently considered the camera. It's what we do with the camera, and that's not true. We use the camera less than 5% of the time, and again, it's not about the camera, it's about what we do with it. It's not about those electronic monitoring, it's about what we do with it. It's about the way we're leveraging our resources. It's about how we work as a team. It's about how we fill in the gaps of care delivery through another set of eyes. So again, a lot of us get really focused on the technical aspect, but it's the way we are changing our practicing medicine that is, for me, the Tele-ICU. This is, again, by no means a fixed recipe, but this is what was considered EICU could do, and of course, depending on the needs and the resources, we can expand. We can do only part of it or do more. For instance, the EICU core, which could be an offsite or could be in a tertiary hospital, like in ours, it is part of the tertiary hospital, can monitor the medical ICU, surgical ICU, emergency room, step-down unit, and it can expand to community hospital, cover their ICU and even PACU, and of course it can be expanded to critical access hospitals and cover their ICUs or EDs. It depends. Again, there is no fixed recipe, and we can expand it depending on what we want. So the sky is the limit. But again, most of the time, EICU core intensivists and critical care nurses cover ICUs, but again, there are other options according to the needs and of course the innovation and the vision of the leaders of that institution. This is Cecily, our clinical manager, who unfortunately is leaving us for personal reasons, and she is at the core monitoring on the left side. The 4 monitors on the left side is what we call the eCare manager, and there are multiple screens. Then we can open up patients' charts, look at the trends that I will be talking about briefly in the next slides. We can look at the monitors on the very right side, the EKG, the blood pressure, the heart rate, the 5 or 6 vital signs that we always consider basic critical care. And of course we can open up a chest x-ray. We have a better monitor at the physician station, and that's the view we have. In fact, that white building on the top right corner is the Native Hospital just across the street. It's a beautiful hospital, mainly taking care of Native population in Alaska, and of course we have one of the most beautiful views of any ICU. This is again just going a little bit more into detail and zooming in how the Tele-ICU works. It's a combination of things. It's a combination of computer intelligence that has been adopted by Philips, and they have set up some software programs that looks at trends. In other words, just stepping back and telling you a little bit more about critical care, they have looked at disastrous changes like patients coding cardiopulmonary arrest, and they realized that consistently, with few exceptions, a lot of vital signs change over a period of time before the patient's code. and they put this data in the computer, they develop some software program, and then they realize the software program can alert us with some changes. To give you an example, for instance, if the patient starts to bleed slowly post-operatively, the heart rate will go up and the blood pressure goes down. It probably will not be noticeable in minutes or maybe in 1 or 2 hours, but if in 2-3 hours, if the trends go in the wrong direction, the computer will set up an alarm and the nurses will screen that, and if it's something that needs further attention, it will be passed on to the intensivist and he or she will address that. For instance, if it's a post-op patient, I would go ahead and repeat a blood level, we call it H&H. And if I see a drop, I will call the surgeon about this change, and he or she may appropriately get involved. It has happened. In fact, this example has happened. The other level is the critical care nurses that, of course, screen those smart alerts. They call them smart alerts, these red flags that are generated by the computer system. And of course they screen that, they talk to the nurses at the bedside, they read the chart, and they either take care of it right away or they end up being a false alarm, or they pass it on to the intensivist, a small number of those smart alerts, who will appropriately address those in his turn. So it's a multi-level level. I mean, there are situations where the intensivists get involved right away. There are a lot of situations where the computer intelligence is a false alarm, and that's the problem with any program, that we can raise the threshold up and down and miss opportunities or have too many false alarms. So this program is constantly being reevaluated, and the sensitivity and the specificity of that is getting better and better. And again, the smart alerts look like that. Of course, the shape is changing because the software is becoming, it's getting upgraded pretty much every year. So this may not be the exact monitor, but the concept is the same, that we see a patient number, a room number, with a specific alert. For instance, if I set my heart rate to be alerted less than 45 and more than 110, that alarm goes off. And of course, depending on the clinical situation, I would address that. And there are some red alerts that are probably more critical. And this is another example of the screen regarding heart rate, blood pressure, with the patient's name, patient's number, and they're color coded. Again, I'll be happy to zoom in and give you more information about the technical aspect, but I think everybody's more interested in the big picture. So where is Tele-ICU helpful? And is there any data for that? Of course there is. We think that ongoing critical care will improve survival, will improve ICU length of stay, hospital stay, cost. We think that it can reduce transfers, which is a big deal in our state, in Alaska. As I said, it's associated with risks to the patient. It's associated with enormous costs in the range of thousands of dollars. And of course, the stress to the patients and families, where they have to come with their loved ones, sometimes days after. It is a big issue for us. And of course, retaining staff with the EICU support, both in terms of physicians, nurses, and respiratory therapists. If I can keep them happy, they're more likely to stay. And by the way, we have a pretty large turnover in most of Alaskans' hospitals and in general in every business here. So if we can retain them but increasing satisfaction, it's a big win for us. And of course, bedside clinicians are usually like me. They do multiple tasks. They have outpatient clinic, inpatient clinic, ICU, academics sometimes, and of course they have their own business. So if they can focus on their other tasks as opposed to spending every half an hour with a phone call regarding their ICU patients, they can deliver better care to their other patients as well. Now, regarding these outcomes, there are several it's a huge number of published data which are pouring in pretty much every year that demonstrated the positive impact of EICU, and I'm going to briefly highlight some of them. There are several large studies assessing the impact of the EICU on patient care. These studies mostly, and I emphasize mostly, shown improvement in patient mortality, ICU days, hospital days, ventilator day, and cost. The reason why I'm saying mostly is because there have been a couple of studies, I believe 3 that I know of, that did not show improve in mortality. And I'm glad that they did come up, because if we assessed the same aspect every time, there should be some data that is either unchanged or worse. And of course, the other issue is that it also helps us to figure out where the EICU would be most beneficial. In other words, EICU is not a one-size-fits-all. It's not a program that helps every single patient population, every hospital with every model. And of course, it also shows us that probably the data that mostly is coming from Philips VisiQ is probably not biased. This has been a major critique on the studies that have been published with positive outcome, that the data primarily comes from the data pool that is generated by Philips VisiQ, and that is a valid concern and critique on the data. But the fact that several studies did not show improvement, I think, is a positive thing in general. I highlight only one of these studies that was published in 2004 that studied 2,140 patients, and they showed a reduction in mortality of 26.7%, which is, compared to a lot of interventions that we do in medicine, is a huge number. There are clinicians who are not with the company Philips VisiQ that they say, intensivists that I've talked to, and they say this is the most significant interventions they've seen in their lifetime, which is quite a comment. I'm not going to go into details of these studies, but I just highlighted 6 of the studies with the largest impact on patient mortality, and I go in the next slide to summarize them, that they showed improving mortality, ICU stays, ventilator days, length of stay, and reducing cardiopulmonary arrest. And that is also important. Again, probably using the smart alerts to raise attention to the patients who are slowly deteriorating to prevent cardiopulmonary arrest. But mortality and length of stay are huge outcomes. In fact, ICU length of stay and hospital stay are the major costs for any ICU. And if we could reduce that, that would be beneficial. Best practices. I mean, again, I'm not going to go into details about these studies, but just put them out there. You're welcome to ask me to send them to you if you're interested. But there are many, many studies that show that by doing the multidisciplinary rounds, by having somebody who fills in the gaps and takes care of the patient 24/7, when the bedside intensivist is not available, we can improve the best practices, which in turn have shown by other studies that would improve outcome. An example would be application of sepsis protocol that, based on many, many studies in the US, in Australia, and in Europe, that shows improving outcome by 30%, improving survival by 30%. It's a huge number. The summary of best practice studies improving compliance with ventilator bundles, sepsis protocols, and ICU standards of care like GI prophylaxis, DVT prophylaxis, and glucose control. How about finances? How does TeleICU help with the finances? The summary of the studies in the previous slide show reduction in the cost and increasing revenue by sharing resources, of course, and better billing documentation. Transports, again, the larger the state, the more expensive it gets, and better retention through job satisfaction. It is estimated that in Alaska, that was a study by Alaska State, that it takes about $250,000 to recruit a new physician to the state of Alaska, and about $60,000 to $70,000 to recruit a critical care nurse to the state of Alaska. So these are expensive. So if we can retain them more, we can save money in addition to everything else. I'm not going to go into details, but TeleICU has been shown to improve medical education and, of course, in community and rural outreach. I just skipped those. I mean, there's a research institute who has a pool of millions of hospital days in the ICU, and we can gather data from that. Now, specifically, now we're zooming in, and this was more generic about TeleICU in general, but the status in the USA, and I only have a couple of slides to just give you an overview. Many hospitals, after 2000, when the VisiQ/Philips started the TeleICU, they started to adopt this model, and they decided to incorporate EICU as a 24-hour MD coverage, or at least during the off-duty hours of their intensivists. In our case, it's only at night. And since then, the number of hospitals adopting this model, the number of hospitals adopting this model is growing very rapidly. In fact, I show you a curve on one of the next slides that it's like an upward trend like that, which is quite amazing. The first site, again, was in 2000 in Baltimore, and by the end of this year, 49 ICU programs will be operating nationwide, and they will be covering about 7,000 of ICU beds, somewhere between 10 to 15% of the total beds. This is not my slide. I got it from Philips VisiQ, but that's the best I could find to just show you a geographic distribution of the EICU centers in the nation. The vast majority, of course, are East Coast and Midwest. And once we get through the midline going to Mountain West and the West Coast, we see pretty much only concentrated in the Sutter area, in Sacramento area, California, in Banner, in Arizona area, and of course in Seattle. But the vast majority of the states have either none, on the west side, have either none or very few. So there's a tremendous opportunity to connect those patients. And in fact, these are the areas where the resources are very few, and of course there's tons of geographical and logistical challenges for us. So there's a tremendous opportunity if we want to go there. This is the curve that I wanted to talk about. I'm sorry about the size of the curve, but the last number is 2012, and it's about 7,000, and you can see how steep the curve of the increase of the number of beds and TeleICU in the US is, and you can predict what it will look like over the next couple of years or decades. And that's despite the economical challenges we had over the last 5-6 years. The trend has been very, very positive. Okay, how do I get? This is again a slide that I borrowed from one of the national leaders that TeleICU is care provided to critical ill patients by remotely located healthcare professionals using audio, video, and electronic links to leverage technical, informational, and clinical resources, with emphasis on leveraging these resources. I added also another comment from a national leader. His name is Jeremy Kahn, and he was asked to look at the data behind the TeleICU to make recommendations for or against TeleICU as an independent, unbiased resource. And what he came up with, that he did say that the data is the research studies have been not adequately powered or have not been designed consistently, so it's hard to make a definitive comment. But what he said was this: the question is no longer if we should use health information technology, telemedicine, in the care of patients, but how we should use it and what we learn from it. And that's something I completely agree with. And again, like I said before, it's not about, it's not a one-size-fits-all. There are hospitals that would benefit more from that than other hospitals. Without having any data behind it, I think the sicker the patient population, the larger the number, the more that hospital will benefit from that. The example I'm using is buying a hybrid car and trying to save money for gas. My work is only 2.5 miles from my house, and if I want to buy a hybrid car and spend a significant amount above a regular car, the curve of separating cost and benefit ratio will probably not separate because I'm not driving enough. The same, but if I live, like, say, an hour from my house, that curve will separate very, very quickly, and I would have financial benefits from using a hybrid car. The same applies to TeleICU. If I spend a significant amount of money for the startup and maintenance of my ICU, but I'm not using it, I would not benefit from that. And that's probably, we see some of the studies did not show an improvement in outcome and cost-benefit ratio. But again, the research has been limited, and one thing Dr. Khan said is that it is hard to really do a randomized, controlled, blinded study in a tele-ICU setting. How can you blind people to that when some patients are getting tele-ICU, the other ones aren't? And of course, during the course of any ICU, we do so many different interventions, such as changing protocols, staffing changes, etc., that it's hard to attribute any change in the outcome to one single intervention. And these are challenges that we face, and we may never see a very, very strong double-blinded randomized control trial in the tele-ICU, but we'll see. Switching gear to Providence, what do we do? And again, there are pros and cons about me going into details about Providence. Pros is that we may have very similar resources and challenges in the northwest of the US in terms of having a centralized tertiary hospital and having several smaller ICUs that are being cared for. But you may say, among 49 states, why should I care about more details about you? And I just briefly tell you about a couple of slides, and Cecily and I will be happy to answer questions if you have specifics about Providence. But what do we do at Providence ICU? We have a 24/7 critical care support with the nurses. The physicians come between 9 p.m. and 7 a.m. for 10 hours, and that's mainly the hours where there's no bedside physician available. We have a two-way real-time video communication with the nursing staff and the physicians at the bedside. We monitor the vital signs, we monitor the labs, medications, we do standardized critical care practices by doing a multidisciplinary round in addition to the day multidisciplinary rounds at 10 p.m. And of course we use the smart alerts and other warnings. We use them to intervene appropriately. Who do we currently serve? We started in 2009, January 2009, with our own ICU. It's a 28-bed acute care facility. This average census is about 15-20. It's about 20. And then the next site was Providence Kodiak Medical Center, which is the second largest island in the U.S. The challenge with them is, of course, the resources, but a lot of times also they get weathered in, and the patients end up staying 1 or 2 days with no option to bring the patients to the ICU. So even if they are appropriate for transfer, it's a great resource to have an intensivist follow their patients while they're weathered in and they're stuck on the island. The next site was Providence Seaside Medical Center in Seaside, Oregon. This is our first out-of-state outreach, which has worked pretty well. It's in Oregon, and it's only one mobile cart, but one of the hospitals were, again, far from Portland, Oregon, and they have hospitalists but no intensivists, so we had good success with them, prevented many transfers. And of course, Bartlett Medical Center in Juneau, Alaska was the last outreach that joined our program, and with that, the last capital in the nation with no access to intensivists actually was gone. So Bartlett has now direct access to intensivists, and this is our busiest outreach hospital right now, and they're very satisfied with this outreach. I probably won't go into details with our results, but our ICU mortality is 0.48, which is way better than the national average. If the national average is 1, ours is 0.48, and we're quite proud of our ICU mortality. Having said that, we cannot take credit for that alone. There are many other interventions that are being done on a monthly basis in our ICU. But this is something that we look at it proudly. Improving clinical outcomes, ventilator bundles have improved from 86 to 98%. Our glucose control has improved. We have reduced transfers from outreach facilities. It's a huge deal, and we're quite proud of that. And improving compliance with mandatory regulations such as restraints, which is not necessarily an outcome. It doesn't improve survival, anything like that, but it's a big deal for any hospital to get a citation about restraints, and we have been very compliant for many years, many months right now. And of course, the supports that the nurses get, the new nurses get from the critical care, is a key component of ours. We're getting close to the end. I know I need to wrap it up quickly. How can we help them? Again, I'm pretty much repeating what I said, so I just skip through the next slide. I am going to skip through this one as well, so we have time for questions. I think it's worth talking about the barriers. It's not an easy process, and there are, of course, limitations to the ICU as well. I think the main challenge is changing in our culture, changing in our workflow, changing in the care delivery. And I'm, as a physician, even being in charge of being part of this project, startup of this project, I remember when I was signing out my own bedside patient to the EICU doctor, there was some sense of, should I be really doing that? Because it's a new change, and we hate losing control of our patients, and this is something that requires a lot of education, a lot of practice, and now EICU has become part of our care delivery. It's like one team. The bedsides and the EICU doctors work side by side. We're not replacing them. We're just additional support. We're their eyes and ears. Again, the same applies to anxiety about control, which I already talked about. Reimbursement models, it's a major challenge as of now. There are reimbursements for TeleICU. It's not consistent, and it's not 100%. So this is an expensive project, an expensive program, and lack of reimbursement or partial reimbursement has been quite a challenge. Hopefully it will change over the next couple of months, years at the federal level. And one major challenge is different systems. Of course, we are using different hospitals, different vendors. It's Philips, it's Cerner, it's Epic. Will probably come to the TeleICU also. And of course, technology grows fast, and the best model that we had as of 2012 may not be the best model in 2015 or 2020. So it's been a challenge, and of course, every system is expensive. There's an initial financial cost and maintenance that a lot of hospitals cannot afford. So if they have a choice between hiring a new respiratory therapist and getting the startup of the TeleICU, they need to really consider those. And some of them have literally very limited resources. Of course, there are grants for startup, but the maintenance is something they need to pay out of their pocket. And of course, getting the information to all providers is important. Again, if some of the clinicians are not on the same page because of lack of information or lack of trust, the program probably will struggle or even may not succeed. This is a summary slide about the critical care being in the middle and preventive strategies that are provided by the TeleICU, evidence-based standardized care that is delivered on a daily basis. Sophisticated technology, again, it's a tool, it's what we do with it is important. Early detection, clinical expertise, and immediate access. These are all key components of TeleICU in delivering critical care and improving outcome. I probably skipped this slide because we're running out of time, but in summary, TeleICU is already part of our care delivery in the state of Alaska and also in the US. Again, I cannot imagine not using TeleICU for my patients anymore because it's so integrated in our care delivery from both sides of the camera. I do work at the bedside as much as I work in the EICU. TeleICU showed improved survival and better compliance with protocols, as well as reduction in transfers. And these are only 3 of the outcomes that I highlighted. There's more to that. It is important to realize, as you know, you're all involved in telehealth, that it's not a replacement for the bedside providers. It's an established tool in helping clinicians redesign the way we deliver critical care in the 21st century. We are another set of eyes. We are an adjunct. We're not a replacement. That's something we need to make sure they know at the beginning. And we hope we can reduce, or better, eliminate the variability in care delivery by providing the standard of critical care to every single patient every day. I probably skipped this one because that's a repetition. And with this slide, which is just, I took it last month at Matanuska Glacier, and that's a hiker on the top left corner, just to see the size. It's not a hiker, it's a climber, ice climber. With this, I end the discussion, and I think we have a couple of minutes for questions. And thank you very much for participating in this talk.
Thank you, Dr. Kamali.
Thank you, Dr. Kamali. That was really...
And I particularly the statement you made, I cannot imagine not using TeleICU. I think I'll steal that and share it around with some providers who are resisting telehealth. If anyone has any questions for Dr. Kamali, please enter them into the Q&A pod on the left. If not, we thank you for attending. We will ask you again to complete the evaluation survey. This webinar is being recorded and will be placed on our website as soon as it's prepared and ready to go. And Dr. Kamali's, Dr. Kamali's PowerPoint is available for download in the Files pod right next to the chat pod. Now we have a question here. Do remote hospitals all have hospitalists? Do the remote hospitals have ICU beds prior to EICU? And remember you're muted, Dr. Kamali.
Right. I think that's an interesting question and good question. It's different in every site. I mean, all the intensivists in the state of Alaska are in Anchorage. There's one exception. There's one in Matsu Regional, which is not in Anchorage. It's like 30, 40 miles north of us. But all of our hospitals' ICUs are managed by either hospitalists in internal medicine or family practice physicians. And let me just read it. Did the remote hospitals have ICU beds? No, they did not have remote ICUs, and it's something that Cecily and I and our IT get involved. If there's an interest in partnering with the TeleICU, we do a site visit and we make recommendations about the equipment need and about the size, the number of the beds. Should it be a fixed bed? Should it be a mobile cart? And then they make a decision based on their needs and their budget, and then we get Philips involved in installing the equipment. But it's generally something that hospitals do not have. Maybe in the future some of the hospitals would consider that, but as of now, no hospital has prior EICU connection before they sign up for a contract. The next question is from Patricia again. Smart alerts, are they customized to each patient? The answer is yes and no. There are, and Cecily can probably add something to that. Depending on the patient, for instance, if I'm concerned about a patient having a heart rate less than 50, I would customize that. But of course, there are some smart alerts about a potassium going above a certain amount that I would get an automated smart alert regarding that change. But there is some flexibility to do that. Cecily, do you want to add anything to that? Of course, I think Cecily is going to be with us until October, hopefully a little bit longer. But Cecily's email is available through Marta. And she's typing right now. Thank you, Cecily, for the comment. I mean, she did say that they can be adjusted according to the patient's diagnosis and the status. Of course, Bob and Martha are both available for questions. And of course, I'm available as well. Again, this is a very broad topic and it's hard to bring everything in a 45-minute presentation, and I'll be happy to be answering any questions if they arise in the future. And if you want more information regarding contacting your clinicians and or your administration regarding TeleICU, I'll be happy to give you some input based on our experience with our outreach. I don't know what disparate means, but probably you mean different medical records. If this means different electronic medical records, the answer is yes. We prefer that they have the same system, like Providence is going Epic. As of now, we are the only Epic, the Anchorage, Providence Anchorage is the only Epic center. So we end up getting faxes and or the need to get on their electronic system after we get permission to get more information about the patient, like looking at their charts, looking at their history and physical, looking at their labs. That would not be an issue for Providence further down the road, but for other outreach systems that have a different electronic medical record, it's been a challenge, but it is realistic and it's doable, and we are doing it. I hope that answers your question, Patricia.
Over a little over time.
A little over time. He was a doctor. Thank you. You can contact Martha,
and we'll get a hold.
Of Dr. Kamali, or we'll have
your questions. Again, nrtrc.org, the website. This presentation will be recorded and uploaded up there. And thank you all for attending.
My pleasure. Thank you so much for organizing.